Hi, my name is Tasha Allen. I'm a neonatal occupational therapist at Centennial Children's Hospital, and I'm here to discuss the non-pharmacological care of the NAS infant. These infants require different techniques for swaddling, bathing, and diaper changes, and I will be demonstrating how to do that, as well as how to include parents in this care so that they are prepared to take this infant home. This is Ian, and as you can see, I have his arms swaddled down and his legs are out. So we're going to go ahead and put him in the water. Let him get adjusted. And the whole point of it is to let him settle in. So what I do is I keep some extra water and I just pour the water over the towel. Okay. And what we're going to do, as you can see, we just give him a chance to settle in, and we're just going to give him some pressure. So I'm resting my hands on his legs. So Mom, if you want to come over here and I'll show you how to do that. Okay. So you want to give him some nice pressure on his legs. That way he can stay calm. We'll just give him some time. We're not going to rush. We're going to move nice and slow and make sure he stays warm. With swaddle bathing, we just do one body part at a time. And we're not going to do any scrubbing or washcloths because that texture tends to be overstimulating. So what we're going to do is just put the soap directly in your hand. You can kind of rub your You can just kind of rub your hands together. And you're just going to give him deep pressure to wash, just like that. So it's kind of like you're massaging him. Just go down the leg. And then you can go at the bottom of the foot. And then when you're done with one leg, then you're going to cover it back up. And then we're going to take the other leg out. And then we're just going to cover that leg up. And so you do the lower body first, and then we're going to do his head. So it's the same technique. You're not going to do any rubbing or fast movements. It's going to be nice and slow and deep pressure like that. You're just going to kind of massage the scalp like that. That's so relaxing. Oh, good job. And then for the arms, we're just going to take one arm at a time. So I try to keep the chest covered as much as possible, and then just take one arm out at a time, and you can wash that arm. And we're just going nice and slow, not really rushing him through it so he can stay calm. And Tama, you're done. Okay, so what we're going to do, this is called a halo sleep sack. So these are great. It's a great investment if your hospital can purchase just a couple, 2 or 3 of these for an infant to use while they're in the hospital. It helps to decrease the overactive Moro reflex and keep them calm and contained. So the first step is you're going to bring the arm by the side. We're used to swaddling with the arms up, but for these babies we're going to do the arms down. And it's a tight, secure swaddle, so you're going to bring it pretty tight, and then you're going to kind of tuck it under the baby like that, so they feel nice and contained, and then you're also following the appropriate safe sleep precautions. So if you do not have a sleep sack available, this is a technique you can use with a blanket. This is a regular standard baby blanket. You'll need a larger one aside from the hospital if they're, depending on their size, but it's the same technique. You're going to tuck it in. The arm is by his side. Then you're going to bring the bottom part up. And it's still going to be a nice, tight, secure swaddle. So you're going to bring this up and tuck that. And bring the arm by the side. So it requires a little more effort than the sleep sack, but the whole point is that you're still giving him a nice, tight swaddle. When you're doing a diaper change or any type of care, if you can keep the arms swaddled by the side, it decreases the tremors and the overactive Moro startle reflex, and that way the baby will be calm. Okay, just to review some important points of what we just covered in that video, I would just like to list off 3 important points. The first one would be to remember to always swaddle the baby with the arms by the side. The standard technique is to bring the hands to the face. For an NAS infant, it is a much more calming technique to swaddle very securely and tightly with the arms by the side. And the second point would be when you are doing your bathing, take your time and try to keep the environment calm with not using washcloths, using your hands, doing deep pressure massage, and keeping the baby covered as much as possible and just exposing one body part at a time. And the third thing would be to include the parent in that process as much as possible. You actually get more parent involvement while the baby is in the hospital if you allow them to see how they can help comfort that baby. And it also gives them some techniques to take care of the baby at home.
Hi, I'm Erin Munn. I'm a child life specialist at Monroe Carroll Jr. Children's Hospital at Vanderbilt. I work specifically with Team Hope, our hospital's approach to improving care for children, newborns that have had opioid exposure in utero, with their moms and their family members. I was asked to speak to how to engage and involve the families, moms in particular, in the care with their infant. And I think of 3 main ways to do that. First is really a key factor is treating these moms with dignity and respect. Secondly, to engage them as partners in care. And third, to prepare them for what to expect, both in the prenatal period. So for those of you that are in the maternal arm, thinking in that frame. And then also during the course when they're admitted for delivery, in the postpartum period when they're a patient and hopefully their infant is able to stay with them in the room, and then preparing them for transitions at time of discharge, mom's discharge, when the baby is going to stay in the hospital a little bit longer. I think one of the really useful things to keep in mind with trauma-informed care is to approach it as a universal precautions approach, so anticipating that every family that we work with, every person that we engage with as part of our work has some trauma history and would benefit from the actions that we take in practicing from a trauma-informed approach. Some of the things that I like to keep in mind for myself and sometimes help others who are challenged and trying to find their way in working with these families and these moms is to avoid judgment and work from a place of empathy, and to recognize that many of the behaviors and strategies have developed as a way to survive, to adapt and to cope with really difficult and challenging situations. They have had to create behaviors that may not be healthy in the long run, but have helped them to get through some really difficult experiences in their life. To keep that in mind, to keep in mind that recovery is a long process, and that it's something that takes time and takes lots of support. So engaging moms in that process, providing reinforcement and encouragement for the choices that they've already made to seek care, to engage in recovery, how they've already made the best choices for their infant to seek out medication-assisted treatment during pregnancy. Those are all important ways to acknowledge and empower women in this situation. And through making that connection with them, with the trauma-informed understanding, we're able to build trust and collaboration between moms and other family members and the infant's care team, which is where I spend the majority of my time working after the baby's delivered, engaging moms and their family members in the care of that child. I think it's also important to consider our own preconceptions, our attitudes, and how that might create situations in which we may have a tendency to present as judgmental, or even how we engage in ways that a family could find or a mom could find almost punitive. I think of the conversations around DCS involvement. Moms often see that as a more of a punitive measure, and if we can talk with them about that process and prepare them for what to expect with that process, engage them in how to tell their story so that they can speak to the good decisions that they've made, the steps that they're taking in their life. It may not change their perception entirely, but helping them through that process, I think, can be very helpful because so many have experienced trauma with authority in the past. I think another really important factor to consider is to emphasize for moms and other family members a sense of physical and emotional safety. If someone feels unsafe, they're very unlikely to be able to engage in connection. And for this population, for these moms, it's so important for them. We are encouraging them to engage with their infant, to create connection and develop attachment with their infant as part of the supportive non-pharmacological interventions that have been shown to make a big difference for opioid-exposed newborns. And so for them to have that sense of safety in our environments, if we can be welcoming to moms, to invite them in, to encourage them and empower them, and by empower, I mean to share power with these moms so that they feel empowered in the care of their infant. Sharing power with, helping them recognize they already know things about their baby, their infant, that we don't know. From the time spent during pregnancy, feeling their infant's rhythms of activity and quietness. The infant knowing their moms and recognizing their mom's voice can be really powerful as a reminder for these moms to recognize the very unique position they have in their infant's life. And so sort of supporting that and empowering them in that role can be really important for engaging them and involving them in care. In a NICU setting, it can be as simple as welcoming, inviting mom in, and making sure that there's already a chair at bedside so that she can sit down and spend some time, not just stand at the infant's bedside as if she's going to be walking away any minute, but sit down and settle in for some time. I think some other suggestions are reminding moms that you know your baby. What you're seeing is also important in their care. So asking them, what are some of the things that you've been noticing? What are some of the things that you are feeling comfortable with or less comfortable with in how your baby's responding to treatment. How are you feeling about these two options, and asking for their preferences, engaging them in directing care within the bounds of appropriate medical suggestions and direction, but encouraging them to participate in that way. And that's really empowering them for the future and how to communicate with their child's care providers as well, and even their own care providers, how to have those conversations. We can model that during the infant's admission. Another really important thing to consider with engaging moms, and particularly around that sense of felt safety, is that we need to hold ourselves accountable to communicating clear information transparently. I think that people who've been hurt in the past, who have been struggling, have a radar that picks up on if information's being held back from them. And we can ease the pathway for that collaboration between the mom and the family and our team in the best interest of the child by making sure that we're communicating clearly and with transparency. I think something else that also ties into that sense of felt safety is the idea of preparing moms for what to expect at different steps along the way. So both in the prenatal period, helping them understand what to expect as they are arriving at the hospital for delivery. What is that sequence of events that will take place? What is the best estimate on the timing of each, how long it will take or when it will happen, can be helpful information. The more information that we can provide of a typical experience based on our understanding of each individual mom's situation or infant situation, the greater sense of predictability there is for that mom, the greater the sense of safety and that stress that would be spent in dealing with the uncertainty or worry about the unknown can be, that stress and that energy can be set aside and focused on more productive things. So preparing verbally and with written information is really helpful for these moms. At each point along the way. There's some good resources in the toolkit, information about the care in the hospital that can help moms and family members feel that things are more predictable, that they have an understanding of what to expect, and things about that transition to home. When the infant's ready to discharge from the hospital, what is that transition to home going to look like, and what can they do to be prepared for that?
Hi, I'm Betty McDaniel Thomas. I'm an RN and lactation consultant at Monroe Carroll Jr. Children's Hospital at Vanderbilt. I want to talk about breastfeeding and the opioid exposed neonate. There's 5 points I really want to talk about. The first is, what does mom want to do? Does she want to breastfeed? Does she want to pump and breastfeed? Does she want to just pump and offer her milk to her baby? All of those options are perfectly fine, and you can give her those options because there are no rules to breastfeeding. And you really need to just encourage her. We want her milk if she just desires to pump, even just for a short time. The second point I'd like to make is education. We want to make sure that she's educated on the lactation process, meaning she'll have colostrum the very first few days. It is very, very small amounts, but it's perfect for her baby. And small amounts given to the baby may help the baby withdraw some, just slightly, but just be sure and let her know that. And that her milk will come in, or lactogenesis 2 will begin in anywhere from 2 to 5 days. And because we want her to know that her milk's going to come in, and it might be a little uncomfortable, but lots of pumping will help decrease any engorgement. It also may help with bonding with her baby to provide skin to skin. It helps calm her baby, and it may get her closer to her baby a little bit. The third point I'd like to make is realistic breastfeeding. These babies may not breastfeed just absolutely perfect. You might see disorganized suck, biting or chewing. So we want to make sure mom is aware of these things, and things will get better if she desires to breastfeed. Also, her frustration level, she may have a really low frustration level. So you have to be very calm, you have to be patient with her. And if she says, I can't do this anymore, say okay and back off. The other is you have to ask permission to touch. Some of these women are very sensitive to touch. Be very aware of how she reacts to that. Have her just attempt to breastfeed maybe only 5 or 10 minutes and see where it goes. The baby's breastfeeding great, leave it alone, let her enjoy it. If not, stop and maybe try again. And reassure mom, lots of praise and reassurance that it will get better with time and patience. The fourth point would be pumping. Because these babies are such high risk for increased weight loss and irritability, we want these moms pumping as soon as possible after birth because we want them to produce as much milk as they can. So keep her pumping. Again, if you notice any hesitation when you touch her body, or she feels any tension there, just explain how to pump instead of doing any touching. Just be very aware of their reaction to it. So pumping soon after, and let her know what the volumes are going to be when she is pumping. The fifth point I'd like to make is supplementation. These babies will need to be supplemented because of their high caloric needs. Because of withdrawing, they're going to expend a lot of calories. So offering them a supplement. And be sure to tell mom, too, that these babies will need to be supplemented along with her breast milk. Her breast milk is perfect for her baby, but this is a medical need actually for her baby. So we want to be sure and teach mom consistency and patience, and be sure to praise and reassure mom things will get better.